Thank you very much, Mr. Chairman, dear colleagues, ladies and gentlemen. It's my honor to be here. So the new classification is my topic. Just to be on time, let us go fast through it. Believe me, I am not changing the program from venous to aortic, but giving you an impression why we need such a classification. At the left side, you see a thoracoabdominal aortic aneurysm. At the right side, you see a AAA. And we have a big aortic center. Michael Jacobs is my chief, is the chair. So I think he would go crazy if I make a research and I put all patients with thoracoabdominal aneurysm and AAA just in one paper and show you the result of them and say we had a lethality of 10% and paraplegia of 6%. It doesn't make any sense because these both pathologies, as you can see, are both aortic aneurysm, but there are words between it. And exactly the same problem we have with chronic venous obstruction. As you can see on this slide, we have four kinds of chronic venous obstruction, assuming the gray area is a chronic or post-thrombotic changes. So now, going into detail, just let us comparing the left one with the right one. Both are called PTS. And at the left side, as you can see, you see the corresponding venous map. We have perfect inflow. At the right side, we have no inflow. We cannot compare these two patients together and call them both PTS. So there is a need of classification. This slide shows you it is a study of Olivia Hartung about chronic venous obstruction patients. As you can see, included only the chronic post-thrombotic occlusion lesions. And going into the detail, have a look on the primary patency. There are big differences. For example, Raju with 30% of primary patency comparing to Olivia Hartung 84. Or going to the secondary patency, even big differences. So what is the problem? We know that Raju has the most or the biggest experience. I don't think that Raju is doing a bad job. The problem is they are including totally different patients with post-thrombotic changes. And the main point is the inflow. So this is the proposed classification. Just have a small look on it. The classification is based on anatomical expansion of the post-thrombotic changes, the trabeculation, assuming the impact or the inflow, the lumen is reduced over 50%. That is a real significant involvement. So the classification should be based on anatomical expansion, and the inflow is the most important thing. To ensure clinical utility, we propose a simple classification, like type A, type B dissection. Of course, we can include 100 other sources and important things we can discuss about it, but a difficult classification won't be used and don't help us. We know, of course, there are big cases with involvement of CAVA or both sides. But believe me, from my experience and experience of other big centers, if the inflow is good, if the inflow is very good, it doesn't give a big impact if CAVA is involved or not. The stent or the result will be good. And we are not only talking about result, we are talking about clinical outcomes and drainage of the leg. This is the most important thing. So we only focus on iliac tract. In this classification, again, more than 50% it's assumed as clinically significant. These are the participating centers. And this is just a preliminary validating of 1/3 of patients we are receiving from these 14 or 15 centers. And just have a look on the number CAP classification. From left, from group 1 to group 4A and 4B, you see the severity of the disease is getting bigger. And going into the venous claudication, group 1, just 9 patients or 4.3, and group 4A and 4B, 100%. And looking on the primary or secondary patency, you see big differences between this group. So this is the classification, and we use it also for recommendation of treatment. Group 1 needs only an endovascular treatment. Group 2, endovascular. Group 3 can be also managed in an endovascular manner. But then we come to the so-called extensive chronic venous obstruction, which needs, as for A, endovascular endophlebectomy, endovascular treatment of the iliac tract plus endophlebectomy, or endovascular treatment and stenting into the deep femoral vein. For B, again, endovascular plus endophlebectomy as a hybrid procedure or stenting into the femoral vein. And the group 5 should be considered as contraindication. So the clinical impact of this classification is to aid scientific reporting, comparison of results between studies, comparison of stent outcomes, to ease the decision-making for indication or contraindication, and support the therapeutic decision endo, hybrid, conservative, and probably duration and type of anticoagulation, and to predict outcome easier while we are talking to our patients. Thank you very much.